Welcome to Ask Alumni, the podcast where we talk to alumni of Loma Linda University School of Medicine to gain insights and information to help students and young alumni on their medical journey. Hello, my name is Calvin Chuang and I'm your host today. And today we're going to be talking to Gisella Laverne Sandy, Loma Linda University class of 1998, about the wonderful world of trauma and general surgery. Dr. Sandy, welcome to the podcast.
Thank you. Thank you for having me.
Now, you are a trauma and general surgeon. I am not familiar with this as I am not medical. So can you please kind of describe this specialty for me?
So general surgery, you're probably familiar with. Trauma is a subset of general surgery. A lot of surgeons do trauma without having done a fellowship, but a lot of places are now requiring fellowship training in critical care in order to do trauma, and trauma and critical care training usually go together. So even though there are some general surgery residencies that are trauma light and they don't get a lot of experience in trauma. At Loma Linda, at least when I graduated, it was trauma heavy. So I was very comfortable with trauma when I finished, but I did the fellowship anyways because of requirements of other jobs later on.
Oh, great. And how did you stumble into this realm? Did you always want to be like a general surgeon or a trauma surgeon?
Stumbling is actually a good description. So I've known since I was a little girl that I wanted to be a surgeon. And actually my initial thought was that I wanted to do thoracic surgery. But when I was on my thoracic surgery rotation, I'd run in at 5 o'clock in the morning and I'd see that my attendings were already all in the hospital and they had been there a long time. And when I would leave at 8 o'clock at night, they were still in the OR. Wow. And I thought, maybe this isn't exactly what I had in mind. So I settled on general surgery. And like I mentioned, Loma Linda was very heavy in trauma, the training that we got. And I honestly, when I was finishing my 5th year, I was going through a lot of personal stuff. My father was very ill. And honestly, I didn't look for a job. I was just trying to finish. And one of my attendings, he was like, I have some friends out at the community hospital. Why don't you go and talk to them? There's a trauma position. So that's how I ended up in trauma. And I actually, I knew that I liked trauma when I was a student and when I was a resident, but I never had considered, going into trauma, specializing it. But that's where I ended up. And it actually turns out to be a really good fit.
It's interesting that you saw through observation the lifestyle of other surgeons, and you're like, yeah, that's not for me.
Well, I like sunlight. And, if you're in the hospital before 5 o'clock in the morning and at 8 o'clock, you're not getting any sunlight.
So I'm guessing that's one of the perks of your current specialty. What are some of the other aspects of your specialty that you really like about it?
So with trauma surgery, there's a lot of versatility depending on the practice location. If you do trauma in an academic setting, you can do trauma, you can do acute care general surgery, which is mostly the emergency stuff. And then you can also have a general surgery practice if that's what your interests lie. In private practice, depending on the practice setting you get, if you end up in a setting that's a very trauma heavy, busy institution, there are some trauma surgeons that do only trauma. Critical care, you can do trauma, you can do critical care, you can do general surgery. It's a versatility that I don't see in that many other specialties.
So a lot of variety, it sounds like.
You can have a lot of variety depending on where you end up. Like my first job after I finished my trauma critical care training, I was doing critical care and trauma and general surgery all at the same time. It was a little overwhelming, but yeah, if you like it, and if you like all of the different aspects of it, you can do all of it, or you could choose one aspect.
And I imagine with trauma, it's a pretty fast-paced environment. Is that right?
So trauma is fast paced for the most part, at least when you're on call, definitely. um, when I was in my training, I actually didn't know this about myself until much later. I'm a bit of a trauma junkie. So not of an adrenaline junkie rather. So trauma feeds that.
Interesting. Yeah. Okay. That would make sense. Is it, you do like the adrenaline, although you're probably seeing a lot of pretty horrific cases that come in. Does that take a toll after a bit of time?
Absolutely does take an emotional toll on you. And you have to. So when I was younger, I didn't actually realize it. I was just so busy getting through and getting done, and then doing the job, taking care of the patients, and it kind of piled up on me. My first job out of training, the one that my attending pushed me into, I actually got really burned out because of the emotional trauma that comes with trauma, and in some practice settings, you are better set up to deal with that. Like where where we did our training, it's a big team. There are all sorts of people around, and, everyone on the team is traumatized at the same, when the traumas come in. But where I was in private practice, it was just me and the nurses. And there wasn't that whole team of camaraderie, people going through the same thing that kind of, helps you bear the burden. It's just something to keep in mind.
So in those kind of smaller settings where you don't have that shared camaraderie, shared support network, what did you find that kind of helped you, keep on track, stay mentally sane, that kind of thing?
Well, I don't think I stayed mentally sane. So I took a lot of time off. I tried to vacation a lot. I actually had another surgeon that I was office sharing with. So we shared our patient loads. Like, I got time off because he told, we made an arrangement. When he was on call, he would see my patients. And when I was on call, I would see his patients. So we weren't having to be there every day. It made a big difference, but it was, and there are some hospitals that do trauma because trauma is a big moneymaker for hospitals, but they don't have all of the resources that you need to do trauma well. So it's something to keep in mind. Coming out of training, fresh out of training, I didn't really know what to look for, to know what was a good trauma setting, and that wasn't.
So that's interesting. What would you define, now that you've had all this experience, what would you define as a good trauma setting if someone was to go out there and look?
So a good trauma setting, you'd have to speak to the people, on the, in the hospital, but you have to have administration that has buy-in. You have to have all the multiple subspecialties that we rely on in trauma. They also have to have buy-in to the trauma service, because if they don't, you end up what we call babysitting all sorts of patients that aren't necessarily related or necessarily needing to have a trauma surgeon taking care of them. They are simply because everyone else says, I'm not doing that. And it just gets to be overwhelming. And you need to have, the advanced care providers, depending on the robustness of the service. If you have a bunch of surgeons and you have residents, then you don't necessarily need advanced care providers. But if it's just surgeons and there's a heavy patient load, you absolutely need somebody to help manage all of the work.
Okay. That's good information to know. You mentioned before that the academic setting and private settings are quite different. What are the major differences between both settings?
I'm not sure I'm the best person to answer that, because the academic settings in which I've worked, besides in my fellowship, I've worked, in the Loma Linda setting. Well, I suppose it's as good as any. The biggest difference that you first come across is the learners, the multiple levels of learners. So you have medical students, you have nursing students, you have students from all the different ancillary services, and you have residents, and participating in their training, but also participating in the care of the patients. And so you have the responsibility of oversight for these learners, And it's give and take because you have the responsibility of oversight, but they're a help with the workload as well. And, it all depends on your personality and what you enjoy. If you're not somebody who enjoys teaching, then academic institution isn't the place for you.
Right. Was there, when you were going through training, was what you experienced during residency similar to what you experienced after residency, or was there a bit of a difference between both settings?
My first practice setting was very not academic. Like the surgeons that were there had trained like before the dawn of time. And they weren't very current in like current trauma management. And so, there's that whole morbidity and mortality, the review of practice that they might say, well, I would have done this. You're like, but because you trained before the dawn of time. So it's just, there's so many variables when it comes to choosing a practice location. And I was woefully ignorant of all of them. And, the places where I practiced, I just like ended up there. I learned a lot, though. It'd be nice to be able to prevent some people from making the mistakes that I made.
And that's one of the beautiful things about this podcast is if they listen to it, they can learn from your experience. Now, you mentioned it's interesting. You just mentioned that you walked into this practice where people who have had previous training have it's evolved over time. In the time that you've actually been in practice, have you noticed the field actually evolve over time?
There have been a lot of technologies that have come into practice that I'm not familiar with, like most notably like robotic practice, more so in general surgery. But even still, the more advanced laparoscopic surgery that I did some of when I was a resident, but, there's some centers where, trauma patients sometimes will go for a laparoscopic procedure. Whereas when I trained, that was just, a big no-no. You don't do that. So yeah, there has been a shift to more minimally invasive surgeries for more advanced indications, definitely.
And what do you with these advances in technology, is that something that you keep up with just in general when you do CEs and stuff like that? Or is that something that you have to be like very mindful? I'm going to keep myself up to date in these areas.
You have to be mindful to keep yourself up to date regardless. I mean, you have to, like if I wanted to do robotic surgery, I would have to take a course. I don't really have that much of an interest in it. It's not so applicable in the trauma setting. But even things that aren't quite as major, it's important to stay current with your self-education, because you don't want to be like the dinosaurs that I ran into when I was first in practice.
Right. And I imagine it like keeping up to date is also really good for your patient care as well.
It's good for your patient care. It's good for your brain. It's actually a lot more challenging than you would think when you get into practice, because, the daily work of maintaining a practice, taking care of patients. I mean, surgery is a taskmaster, is a hard taskmaster, and it takes a lot of hours. And when you're putting long hours, the last thing you want to do when you go home is to read an article. But you kind of have to discipline yourself to do it, or else you'll end up being a dinosaur.
And it's interesting how you said a taskmaster. Like, what are the hours like for you? Like, what's the lifestyle like?
It really varies. It depends on what my responsibilities are for the day. If general surgery clinic days, which I almost never do now, tend to be a little bit lighter. Clinic will start at 8 or 9, depending on how aggressive the people are in with scheduling. You'll end at maybe 4, maybe 6, depending on how many patients there are. On the days where I'm doing acute care, the day starts at 7 or before, depending on what I need to do. And it supposedly ends at 5, but sometimes it ends at 6, sometimes it ends at 7, sometimes it ends at 8. The work, it doesn't stop when the clock hits 5. And so it just depends on how busy the day was and what's coming in and who's coming on. It's very variable. And then like the trauma days, it depends on where you are. I just had the misfortune of doing a locums assignment in a place where the surgeons do 4 days of call in a row.
Wow.
And, I've done that in general surgery practices where, you get a few calls a day and that's no big deal. This place was crazy busy. I didn't sleep at all for 48 hours when I first got there.
Whoa. That's crazy.
I think for the 4 days I was there, I slept maybe 10 hours, which, not actually the healthiest thing. Not good for you, not good for your patients. But because of the way general surgery training had been done in the past, there were people that trained in programs where they were on every other night for 5 years or 7 years, depending on how long they were in their programs. And so, surgeons get used to that kind of a rigorous schedule, and they don't necessarily have the resources to seek something else. Or they think, well, I've done it all the time. Why would I do something different?
So that kind of culture from coming through, is that something that there's a little bit of pressure if you were to say, I'm not really comfortable with these kind of hours? Is there there is that internal pressure?
Oh, that is an internal pressure, and it comes from, surgeons ourselves, not just your colleagues, but like I tell people, if I saw me now as I am when I was a resident, I would say I was lazy. It's just, I think about lifestyle and hours and time off and having free time. Whereas when I was going into surgery, I used to tell people, if that is a consideration, if that's important for you, don't go into surgery.
Would you tell people that now?
I would tell people, I would tell people what I also told them before. If you have something else that you could do and be happy, do it. You should only do surgery if it's the only thing that you love and the only thing you can do, be happy doing. Because even with the new work hour restrictions, those work hour restrictions finish when you finish your residency training. And depending on where you go for practice, if you have plenty of help, you can limit, your hours are limited, great. But if you don't.
Yeah. Now you are practicing up in Idaho, correct?
No, actually, no. I don't have a practice here. I have the license, but I haven't gotten any assignments up here.
Oh, okay.
So I travel for work. And so I just relocated here because of the beauty and because I can live anywhere since I travel for work.
Oh, okay. So whereabouts do you go for work and where do you travel to?
So most often I've been in Florida, Arizona, and California. And of course, because I lived in California, it was pretty easy. And California licensing is a little bit more challenging and takes a little bit longer. So if you have a California license, places will tend to use you for California assignments. I've also been to Colorado, Nebraska. I think that's it.
And what is that lifestyle like being, would you call yourself a traveling doctor?
I call myself a vagabond.
A vagabond. So what's the vagabond like? Because there might be people here listening who are interested in having more of a vagabond lifestyle. How do you get into that and how do you work that?
I got into it when I left my last full-time job. I've stumbled into basically everything that I've done. I didn't have a plan. I quit in the middle of the year and I was just like, I'm done. So obviously I had a house, I had bills to pay, I have to do something. So actually before I had stopped working, some of the locums recruiters are pretty aggressive and I had been thinking about quitting. So I gave, I guess, the right answers and they kept hounding me. So I eventually signed up with one of the companies, and it worked out because right about the time that I quit, an assignment came up.
Oh, great. Well, good for you. Now, is that the normal way if you want to
No,
pursue this?
nothing I've done is normal.
Okay.
If you listen to good advice, um, people would tell you that you need to, plan in advance and make sure, you have everything, lined up and in order before you embark on a new journey, before you leave one position. When you're a resident, you really should know where you're going 2 to 3 months in advance, those sorts of things. But I'm a last minute person. I've always been a last minute person. And it doesn't seem like it'll be changing anytime soon.
Yeah. And there's a lot of different personalities that go into the field of medicine. So I'm sure there's other last minute physicians out there as well who will actually empathize with you on that front.
I can imagine.
Now, with different locations, do you find that is there opportunity to practice, say, rurally as opposed to big cities in your specialty?
There are rural locations are starving for surgeons. And the practice patterns that I've gotten into, they can be very different for different people. I tend to like to be at home, so I don't take long assignments. But you can go somewhere for a year as a locums provider. You can go somewhere for 3 months. I tend to not go for more than a week to 10 days. But there are so many different variables that just depends on the opportunities and the needs for different practices.
Mm-hmm. And in the more rural locations, I'm guessing they're you see more different cases and a wider variety of cases in the maybe in the cities you see more specialized, you do more specialized work. Is that the case, or is it different than that?
It really just depends on the community in which the program is located. I haven't done a whole lot of rural assignments because as a surgeon in a rural community, you are also a gastroenterologist, most of the time expected to do screening and emergency colonoscopies, endoscopies. And because I did my training in a highly urbanized setting where there were a gazillion gastroenterologists, and my first 10 years of practice, gastroenterologists were always available. So even though I trained to do endoscopy in my residency, I never did it when I finished. And so now I'm at a point where I would feel like I need to do retraining before I started doing that. So that limits the number of urban assignments that I can get.
Got it. Now, when it comes to, people will be listening, trying to make decisions about specialties. And one of the factors that does come into play is salary. How does a general surgeon fit as far as salary goes, both in the setting of what you said before as a permanent setting as well as a travel setting?
I can't tell you very well about the travel setting because, it all depends on how much you work. If you work full-time as a locums, you could probably make more money than you do in general or trauma surgery.
Okay.
But I don't work full time, so that doesn't count for me. Trauma critical care coming out, I took a salary at a place that was particularly low paying, but coming out of training with fellowship training in trauma critical care, $350 is a reasonable starting salary.
Okay.
In general surgery, $320, $340, you see, there's a wide spectrum. Some places pay a lot less, some places pay more, just depending on, the community, the payers, and all that.
So there's a wide scope, and it sounds like based on lifestyle and how much you're willing to work is also how much money you can make and how much.
Exactly true. Yeah.
Okay, great. We're talking with Dr. Gisella Sandy about trauma surgery. More from her right after this break.
This episode is brought to you by the Paying It Forward Scholarship of the Alumni Association, School of Medicine of Loma Linda University. Every year, junior and senior medical students at Loma Linda University are eligible to receive a scholarship equivalent to half of 1 year's tuition. Students who receive this scholarship also receive advice and encouragement from the alumni who helped fund their scholarship. For more information, visit llusmaa.org/paying-it-forward-scholarship or call 909-558-4633. Support also comes from the Student Ambassador Program of the Alumni Association, School of Medicine of Loma Linda University. Did you know medical students can receive honorariums starting at $500 for encouraging Loma Linda medical alumni to become members of the Alumni Association? Simply have alumni credit you in their perpetual membership upgrade. Help us build our community today. For more information, visit llusmaa.org/student-ambassador or call 909-558-4633.
Welcome back. We're talking to Dr. Gisella Sandy, Loma Linda class of 1998, about trauma and general surgery. We've gone through some of the aspects of your work. Just in general, as you look back so far in your career, what have been some of like the really cool highlights about doing trauma surgery?
Sometimes you get to do exciting surgery sometimes. That's always a rush. But you get to interact with people when they're at a teachable point in their life. As a Christian, a physician, you should always have the perspective of how to reach people for Christ and how to speak a word for God. So, you can't preach at someone who's just been in a car crash, but you can be there for them. You can pray for them. You can do that in many different settings, but usually in the trauma setting, not when they first come in the door, of course. But, as you form relationships with them through their hospitalizations and when they come back, I find that not always, but, there are times where I've had an opportunity to say something that may or may not, make a difference in somebody's life, in the spiritual realm.
Mm-hmm. And is there enough time? It sounds like you have built relationships over time. How much time do you actually get to meet these people that you're helping and interact with them?
It really all depends. It depends on why they come in. And, there's some patients that I see and over the course of 20 minutes and never see them again. If they come in with a trauma that's not very severe and they get discharged. And then there are patients that come in and you have them for weeks on the service. It really all depends on how severely they're injured and what their issues are.
And with the families as well, do you interact much with them?
With the families, you have to interact with them, you to keep them up to date, what's been going on with the patient. But it really depends on the families, how involved they are. There's some families, there's a horde of 20 people waiting, to see how their loved one is doing. And then there's some families that you're calling, you have to get social work or get the police involved trying to find somebody, that's next of kin to the injured person. It really all depends on the family that the patient comes from.
Okay. When you're in this setting, I know obviously you've worked in a variety of settings now. Are you working as part of a team or are you more individualized?
So trauma is a team sport. That's what I like to say. If you have a trauma surgeon, just a trauma surgeon and nobody else, you're not going to be very successful. The most successful trauma institutions have a built up, you need all of the services available. And you need ancillary services, after the patient's been traumatized, they need physical therapy, they need occupational therapy, they need rehabilitation services. There's so many different needs. So it definitely is a team effort. And even, when you're taking a patient to the OR, I remember one particular save that we had. I was working at a setting where I had residents, and a patient came in with a penetrating wound to the heart, and we took him to the OR and we saved him. And the resident says to me, "Dr. Sandy, you saved his life." And I said, "No, he didn't." And I gave him that same spiel. Trauma is a team sport. If it was just me and we didn't have the scrub tech, we didn't have the anesthesiologist, we didn't have the people that are cleaning the instruments, the patient outcome is going to be completely different.
Yeah, that's a good point. Does that build a lot of camaraderie amongst your team? And is it like team sports where that like some people are like, "Oh, I really like working with them," and other people are like, "Oh, they're good, but we just don't gel in that way"?
It all depends on the setting, and it depends on the personality of like the trauma directors and the trauma surgeons that are there. I'm sure you've heard the surgeons don't necessarily have a reputation for having the best personalities. So there are some trauma surgery programs, or even surgery programs that are amazing. The people work together well and it's a great team. And there are other places where you're like, I'm glad I don't work here full time.
Are there any skills that you've learned over time to like ingratiate yourself with the team quickly and to build that trust?
I think my personality from the beginning is I always get along well with people, but you just learn to, people tend to do well when you appreciate their input. And so recognizing people's help, being thankful, I think it goes a long way.
Mm-hmm. That's some good life advice as well. Appreciation. I think a lot of people who, no matter where you are, it's good to be appreciated, but it sounds like in the surgery setting, it goes a long way. So that's awesome. Mm-hmm. Now, in your field, out of curiosity, what's the breakdown like? Is it a lot of men and women? Is it a lot of men? Is it a lot of women? What's the surgery setting like?
Surgery has been known as an old boys club.
Okay.
I think in general surgery, there are more women coming into the practice. And I don't know what the numbers are. In my class, as the cohort of residents that I finished with, 50% of us were women. That's unheard of in some places.
Wow.
I think there was one class that I interacted with when I was still working with Loma Linda. There were 4 women and only 2 men. But, that's kind of an exception. There are definitely more women in general surgery. Not quite as many in trauma surgery. And as you go into the subspecialties, it gets fewer and fewer.
Okay. And did you walk in, you mentioned old boys club, when you finished up during that time, did it feel like an old boys club going into that?
So I have to give a plug for Loma Linda. I trained at Loma Linda, and, the first female surgeon, I think, graduated in the early 80s. And, there are differences in men and women and their personalities and the way they run the service and the way they do things. And my attendings at Loma and Linda had figured out that if they have a woman running their service, it's going to be very organized and things are going to go well. So they had gotten past a lot of the problems that men have with women in the surgical realm. In speaking with other women in training programs in other places, their experience hasn't been nearly as positive as mine was.
Mm. Yeah, well, you know what they say, when women make the world go round. So it's nice that Loma Linda figured that out nice and early. So that's really encouraging to hear. So it sounds like gender, at least, is not going to be as traumatic of a barrier to entry as it probably has been in the past.
It really is dependent on the location. Like, I just met a surgeon who is fresh out of practice, who was the only woman in her program as far as trainees and attendings. And I don't know why they took her into the program, because they didn't treat her well. They didn't let her operate. And she finished her program, went and did a breast fellowship, but she finished her program not being comfortable operating and not being safe. Mm. And she ended up, thankfully, in a program of surgeons who are very supportive and who have helped her get what she needed to practice. But, there are so many so many pitfalls for somebody like that. And, she thankfully ended up in a place where she'll be supported to the point where she is able to practice independently and safely. But this is we're in 2021. She finished in 2020, not being fully trained because of the prejudice and biases of the program director that should never have hired her in the first place.
So it sounds like a good residency is critical, not only for the surgeon, but also for the patients at least, so they're not dangerous. What things should students look out for to make sure that they do land themselves in a good residency program?
I think, when you're interviewing and you need to look around and see who's there. If you see a program, then there are no female attendings. That's something to keep in mind. Women and men, like I mentioned before, they don't work the same. They don't think the same. And, the expectations, sure, you have to be able to fit into a man's world. You have to be able to work with men. But it helps a lot if you have women, that you can relate to, that can kind of show you how it works. And it just, women have done it all the time, and you can do whatever you put your mind to, right? But it makes it a lot easier if there are other women around to help you, go through the process. So if you go to a program and you see that there are no other women, that's something to take in mind. Just, programs are accepting people, diversity, it's a buzzword. Everybody needs diversity for them to be considered as a place of quality. But what diversity means for me isn't necessarily it. So if having one token resident is what you mean by diversity, that's a problem.
Yeah, and speaking on diversity, it's been in the news a lot recently. The rates of Black physicians graduating is still lower. As someone who is, a minority going through, how is your experience going through and being a minority surgeon?
That's a good question. It all depends on, again, where you are, location. And I find you see what you look for. And so when I was going through my residency, looking back, I can see there are instances of perhaps biased treatment. But when I was in the process, I wasn't, I have a goal. I'm training to be a surgeon, and I'm going to do whatever I need to do to get that done. If you don't treat me right, I could take the time to complain, and I didn't have time for that. I just had to keep going.
Right.
It helps to have a support system. It helps. It's another thing to look around. If you go to a program and there is no ethnic diversity, it's not necessarily mean that you wouldn't go there, but it just means that your experience is going to be different. If you go to a place where people base their treatment of you on stereotypes that they've seen in media or that they've learned from nefarious places, it's going to be an experience that's a little bit more challenging than it needs to be.
Yeah, that makes sense. And we are living in a day where that is more in the surface, and people are being more conscious about that. Have you noticed a change as you go into hospitals now that is more clinics and hospitals are being more aware of that?
So the thing is, people are more aware of it, but you can't change people's perspectives. You can't change people's treatment of others by legislation, by shaming them, by all this stuff that's been going on recently. And, if people are hateful, they're going to be hateful. They might hide it a little bit better, but they're still going to be hateful.
Mm-hmm. Yeah. Do you have any advice for students who may be minorities going through at this moment as they go through and they look around and maybe there aren't that many other fellow students? What advice would you give them?
Look for mentors. That's helpful. You have to be open, though, because there are some areas you'll go and there is no one.
Mm.
You just have to be open to find mentors that are willing to be a resource for you, even though they might be different from you. There are some, somebody who acted as a mentor for me, wasn't female, wasn't an ethnic minority, but he was just so incredible help. He was a resource as far as education, advice. He was somebody that I could always call. God puts people in your path that you need, and you just have to be cognizant that they might not necessarily look like what you'd like them to.
Mm. And that's a really interesting insight and aspect that, it could be that the person that helps you is not the person that you're thinking would be the one to help you.
Exactly.
Now let's just go back to surgery here, since that is the main reason we're chatting today. You mentioned a little bit earlier how you've seen some pretty cool cases. Is there, for those listening who are really into surgery and who are like, oh, I want to hear about some cool cases, what has been your coolest case, an interesting case?
So, there are just so many different interesting cases, but the most dramatic cases, I guess, are the people that come in almost dead and then they leave alive. So the story I like to tell is of the young man who came back from Iraq and found his wife was pregnant with another man's baby.
Oh, no.
So he got drunk and he slashed his wrists. And when he didn't bleed to death, he stabbed himself in the chest with a kitchen knife.
Oh, wow.
And, it was so ironic when he came in, he had a stab wound on his left chest that went through his wife's name. I should have, I should have known that there was something there. So he ended up lacerating his right ventricle, and he coded on the way to the operating room, but we were able to get him back, close the wound, and he went home alive.
Oh, wow.
That's pretty dramatic, but it's just, when you go out to speak to somebody's wife after such a traumatic thing, I didn't get that story. All the story I got was that he had slashed his wrist and stabbed himself in the chest. Mm-hmm. And, piecing together the story afterwards is, the trauma that people go through when they traumatize themselves. It's really hard.
Yeah. And I bet with most cases that come through your door, there is a story behind the story, and you probably don't see that. You just see what's in front of you.
No, I try to get the story because it makes difference. It makes difference on how they're going to recover. It makes a difference on where you're going to send them. I try to, I don't actually myself get the story, but usually like the social worker or the nurses, they get the story. And I always try to ask what's actually going on.
Yeah, and it sounds like it's actually helpful for their care. So I guess it's critical to get the story then.
I wouldn't say critical, but it's very helpful.
Okay. What's been the most, that's what we would probably, we'll call that one the interesting, cool story. What's been the one that's the story that you've come away with and saying, that's why I got into this career?
Oh, here's a story. So it was a it's a teenager. He got stabbed in the neck, and took him to the OR for a neck exploration. And for all intents and purposes, the boy should have been dead. The knife went in between the artery and the vein, oh, wow. And did absolutely no damage whatsoever. Wow. So, when he, we fixed him, sent him home, and he came back to the trauma clinic, and I had the opportunity to sit down and talk to him and tell him, I actually, when I saw that he was coming back, I made him a little PowerPoint. So, because he doesn't know anatomy. So I made him a PowerPoint of the anatomy, and I showed him so he could see that he really should be dead. And then I had the opportunity to share, was it Jeremiah 29 with him? For I know the thoughts that I have for you, thoughts of peace and not of evil, to give you an expected end and a hope in a future. And so I know I had the opportunity to tell him, what? God has a purpose for you because you should be dead. You really need to find out what that purpose is.
Oh, wow, man, that's such an impactful story. Wow. Wow. Okay, great. Well, it sounds like, yeah, it does, as you mentioned earlier, provide you a multitude of opportunities to actually get to some pretty deep points with people pretty quickly as well.
Well, in medicine, if you think about it, the world over, when you're going through your history and just talking to people, this is more so in a general surgery because in trauma, you don't get a full history. But nowhere else in the world do you ask somebody about all of the details that you ask somebody in the first 10 minutes in meeting them. You ask them about their sexual history, you ask them about drugs. You get to know somebody on a level that you wouldn't do anywhere else.
So it creates that instant vulnerability, I guess. Well, yeah, the situation does anyway.
The situation where they're more vulnerable. And if you're open to the leading of the Holy Spirit, you can sometimes make a difference.
Okay. Well, I know we're approaching the end of our time. Thank you again. As before we leave, though, are there any pearls or like nuggets of gold of advice that you would give any of our student listeners as they are preparing to choose their career, and maybe it might be to do with surgery, or it might be just in general as a physician or as in life? Is there any nuggets there?
I think nuggets are that coming out of a Christian institution, I think I didn't take as much time figuring out what God wanted for me to do. He's so good. He landed me where I needed to be. But it would be really helpful, if you are a Christian, if you have the background and a relationship with God, to spend time finding out where he can best use you. I think that's really key.
Really solid advice. Well, Dr. Sandy, on behalf of all our listeners, I'd just like to thank you for taking the time to speak with us today. This has been just fascinating listening and having this conversation. So thank you. Thank you for everything.
You're welcome.
And that concludes our episode for today. Ask Alumni is a podcast of the Alumni Association. If you'd like to hear more podcasts like this and more episodes, please visit us at our website, lusmaa.org/podcasts. And if you have any questions or would like to see a specialty featured, please email us at lusmaa@lu.edu. For now, I'm Calvin Chuang. Have a blessed day.